Dear students, we are going to see the clinical anatomy video. Few important clinical anatomy topics related to the head and neck region. First slide, the very interesting one, we are going to see the dangerous area of the scalp. You all know very well there are 5 layers in the scalp. The dangerous area of the scalp is which one? Can you identify? Scalp means S for skin, connective tissue, aponeurosis, loose areolar tissue, and P is for pericranium. So this loose areolar tissue only, it's very important. Look at this loose areolar tissue. It has some veins by the name emissary veins. So from this area, the emissary veins, they are connecting veins which connects the extracranial venous system to the intracranial venous system. So through this emissary veins, it is entered into this main venous system inside the brain, inside the meninges. And here you see this is the parietal bone. Here you will be having the parietal foramen. Through that only the emissary vein passes. Here you will be having the sinus called superior sagittal sinus. The superior sagittal sinus is connected with the superficial middle cerebral vein, because beneath that you will be having the cerebrum. So it is connected to the middle cerebral vein. So what happens? That middle cerebral vein, superficial middle cerebral vein, is one of the tributary of the cavernous sinus. This is how the infection enters into the cavernous sinus and inside the brain. So it is called as inside the cranial cavity. That's why this region of the scalp, loose areolar tissue, the region of the scalp is called as dangerous area of the scalp. So the loose areolar tissue, it has the venous channels. This venous channels via the emissary vein, they are connected to the venous channel present inside the dural folds. That is your superior sagittal sinus here, and from the superior sagittal sinus it is going towards the cavernous sinus. This is the communication. That's why this area is called as dangerous area of the scalp. Number 2, there's another one interesting thing. This is called as black eye. Look at this black eye. Why the eye is appearing black? Again the same reason, because the scalp is limited laterally to the temporal lines, posteriorly to the superior, can you see the superior nuchal lines, but anteriorly you cannot see anything, any bony prominences which limits the scalp. Look at this. Anteriorly you see this muscle, frontalis muscle, which is continuous with the muscles of the eyelid. So what happens whenever there is a bleed beneath the aponeurotic layer, what happens? The bleed will be limited laterally to the temporal lines, posteriorly to the nuchal lines, but anteriorly it cannot be limited. So it is coming, and it is because since the attachment of frontalis is towards the upper eyelid, this blood is coming and it is collected on the upper eyelid. That's why this appears black in color. I mean, this is a hematoma, right? So this is called black eye because of the non-bony attachment of the frontalis muscle, because beneath that only the blood leaks and it is collected around the eye. And then the next one is the cephal hematoma. The difference between the cephal hematoma and the caput. Caput and cephal hematoma, how to differentiate? You see this layer of, that is the last layer called pericranium. This above the bone, it is called pericranium. This pericranium means the outside of the bone is called, the tissue is called as pericranium. This pericranium, it dips down the sutural lines. You can see the sutures. See, look at the sutures. This pericranium, it goes and dips down here, and it goes and dips down here. So what happens if there is any blood collection beneath the periosteum? It is limited to this area. It will not be crossing this area, because pericranium is limited to this area. But if there is any fluid or blood collection above the pericranium, it can cross the suture lines, because above the pericranium it is not limited. So it can cross the suture lines. You can see here, look at this. This is limited to the particular sutural area. This is the sagittal suture and this is the coronal suture. This is limited to this area. So this is called as cephal hematoma. If there is a caput can cross the sutural lines because it lies above the pericranium. So the MCQ is, below the pericranium it is called cephal hematoma. Above the pericranium it crosses the sutural lines. It is called as caput succinidum. So these two are the very important clinical applications of the periosteal layer of the scalp. Pericranium, periosteum, both are same. And then why the scalp wound bleeds a lot? Why? So because scalp has a rich blood supply, and the most important one is all the blood vessels in the scalp, they penetrate. The second layer of the scalp is connective tissue. The connective tissue layer of the scalp, through that only your blood vessels are going. So all the connective tissue layer is tightly adherent to the wall of the blood vessel. So connective tissue doesn't have the capacity to contract. So it will not contract, so the bleeding won't be stopped. Another one is it has a rich blood supply. So throughout the scalp, anteriorly you will be having the supratrochlear and supraorbital. Here in this area you will be having the supratrochlear and supraorbital, and then laterally you will be having the superficial temporal, zygomaticotemporal, and then posteriorly behind the ear you will be having the posterior auricular artery, and near the occipital bone you have the occipital artery. So both the sides you will be having rich blood supply. So throughout you have the rich blood supply, that's why the scalp bleeds a lot. And another one, the most important point is the vessel wall is adherent with the connective tissue layer of the scalp. That's why it is not able to contract, that's why it bleeds. So what happens, you can put a tight tourniquet around this area and you can prevent the bleeding. Otherwise, leave the flap down, so the bleeding will be stopped. Next is wound gape. What is wound gape? Okay, look at this. There are two bellies. This is called frontal belly. This is called occipital belly of occipitofrontalis muscle. This is the midline. These two muscles are connected or attached to this aponeurotic layer called gallia aponeurotica or epicranial aponeurosis. So whenever you make an incision transversely, what will happen? This muscle will be pulling this side, that muscle will be pulling that side. So what will happen? The wound will gape. Okay, gape means it will be torn. So what happens? You need to make a vertical incision and vertical suturing. So this is called wound gape. This is because of the pull of these two muscles. Next, I will move on to the neck. There is something called the cervical plexus. Cervical plexus is just behind the sternocleidomastoid. On upper and middle third of the sternocleidomastoid, you will be having lot of the nerves are coming out. So number one is which is going in an oblique direction along the sternocleidomastoid (MCQ) to the angle of the mandible. It is called as great auricular nerve. And then number two is horizontally one nerve is going, that is called transverse cervical nerve. Another one nerve is coming over the clavicle, that is called supraclavicular nerves. Another one nerve, you could see it is running on the lateral aspect, posterior aspect of the sternocleidomastoid towards the occipital bone, that is called as lesser occipital. All these nerves are together called as cervical plexus. So when you want to anesthetize this area, you need to give a cervical plexus block. So you need to select this area, upper and middle third of the posterior part of the sternocleidomastoid, posterior border of the sternocleidomastoid, and this is how you have to give the injection for biopsy, cervical biopsy. So when you do the cervical biopsy, you have to be careful. You may injure any of these nerves. So this is called cervical plexus. In front of the sternocleidomastoid, you will be having a very important clinical embryological question, that is your branchial cyst, that will be present anterior to the sternocleidomastoid. Branchial cyst is nothing but the fusion of the second and the sixth branchial arch leads to a small opening called the cervical sinus. Usually should be completed by the mesenchyme, but if it doesn't close or fuse, what will happen? That will lead to a space. That space will be collected by a fluid, that is called branchial cyst. Branchial cyst that will be appearing along the anterior border of the sternocleidomastoid, and along the posterior border only will be having the cervical plexus. The next, the most important one is air embolism. What is air embolism? This is your sternocleidomastoid. On the sternocleidomastoid, you could see nice vein, that is your external jugular vein, and this external jugular vein is formed by the posterior division of the retromandibular vein joins with the posterior auricular vein. They both join together and forms the external jugular vein. This jugular vein is running on the sternocleidomastoid, and while coming into this space is called supraclavicular triangle or subclavian triangle. When it comes near the subclavian triangle, look at this, there is a white color thing, that is your investing layer of the deep cervical fascia. This vein pierces the investing layer of the deep cervical fascia and drains into the subclavian vein, because subclavian vein is deep inside. So when it pierces, the wall of the vein is adherent with the deep fascia. Again, it is not able to contract. So whenever there is an injury to the vein, the external air will enter through this, and then it will enter into the subclavian vein, leads to air embolism. It straight away it will enter into the right atrium through the subclavian, joins with the internal jugular, and enters into the right atrium. Okay, so this external jugular vein is entering into the subclavian. Subclavian joins with the internal jugular vein, which is present here, and then they both form the brachiocephalic trunk. That right brachiocephalic trunk and the left brachiocephalic trunk, they join together and forms the SVC, superior vena cava, that will enter into the right atrium. This is the connection of the external jugular vein. So this is how air embolism occurs. This is the picture of the air embolism. Next one is internal jugular vein. Everybody knows there are two heads for the sternocleidomastoid. Between the two heads, the most important vein, internal jugular vein, is formed. You can see the internal jugular vein. So this place is used for central vein catheterization. So internal jugular vein can be easily approachable in this area. This is called lesser supraclavicular triangle. And then here it is lying above, externally placed. Beneath the skin you will be having the external jugular vein, but internal jugular vein is deeply placed. And then here internal jugular vein, straight, it is 45-degree angulation if you keep the patients, and you can measure the jugular venous pulse. So jugular venous pulse indicates the straight picture of the right atrium. So it shows the right pressure of the right atrium, because internal jugular vein is in straight connection with the right atrium. So JVP means jugular venous pulse is measured by inside in the internal jugular vein. It's a very pretty baby, but look at the neck. Neck is shifted towards one side. That is called wry neck or torticollis. It is because of the contraction of the sternocleidomastoid, and it is due to my congenital, might be due to the birth injury. Though the muscle has some hematoma, this hematoma, the clot might have undergone fibrosed. So what happens if there is fibrose? The sternocleidomastoid on this part will be contracted. So this is called, that's why this face is turned towards opposite side and the head is towards the same side. This is called wry neck or torticollis. This is the sternocleidomastoid. Sternocleidomastoid is supplied by the spinal accessory nerve and the proprioceptive fibers from C2, C3 or C3 or C4. This proprioception also you should mention. And this is the sternocleidomastoid, and this is the trapezius, and this is the posterior triangle area, and here is your spinal accessory which supplies the sternocleidomastoid as well as the trapezius muscle. And the next one is the phrenic nerve. So phrenic nerve is lying on the you can see this is the posterior triangle. Here the floor of the posterior triangle is shown here. You have the muscles semispinalis capitis, splenius capitis, and this one is the levator scapulae. On the upper border of the levator scapulae you have the spinal accessory. This is the MCQ. And the next one, the most important MCQ, is between the scalenus anterior and the scalenus medius. You will be having the trunk of the brachial plexus. You can see the trunk of the brachial plexus is here, and on the scalenus anterior you can see the nerve, phrenic nerve is lying on the scalenus anterior. So if there is any accidental injury, intraoperative injury, this leads to the paralysis of the diaphragm. So this is the intraoperative injury of the phrenic nerve. And then the next most important one is supraclavicular nodes, that to the left supraclavicular nodes, you can say, that is called as Virchow's nodes, in which case it is getting enlarged. In abdominal carcinoma, this abdominal, all the lymphatic drainage is draining into the cisterna chyli. From the cisterna chyli it is entering the thorax through the thoracic duct. Thoracic duct is draining into the junction between the internal jugular vein and the subclavian vein, the junction between the internal jugular and the subclavian vein. So this left supraclavicular, left side, so left supraclavicular nodes will be enlarged in GIT malignancy. So this sign is called a Straussius sign, left supraclavicular nodes. Very important surgical anatomic question. Okay, because of the all the abdominal organs are draining into the lymphatic drainage is to the cisterna chyli. Cisterna chyli enters into the thorax, continues into the thorax as thoracic duct. Thoracic duct is draining into the left supraclavicular nodes. The next one is carotid artery. The carotid artery, everybody knows, at the bifurcation of the carotid artery you can see the bulge, that is called as carotid sinus. Inside that you will be having the carotid body. Carotid sinus has the baroreceptors and the carotid body has the chemoreceptors. Baroreceptors is responsible for the blood pressure and the chemoreceptors are responsible for the oxygen carbon dioxide ratio. So what happens, you need to palpate the carotid artery. Where will you palpate the carotid artery? At the C6 transverse process of the C6 vertebra. It's very important. Transverse process of the cervical 6 vertebra, that is called as Sachsenach's tubercle. In all the MCQs it will be asked. Sachsenach's tubercle, that is the area transverse process of C6. There only you have to palpate for the carotid pulse, because always the pulse has to be palpated over the bony prominence. So here you could see where the carotid artery bifurcates at the upper border of the thyroid cartilage or the cervical intervertebral disc between C3 and C4 cervical vertebra. This is the correct answer where it bifurcates. And common carotid originates at the sternoclavicular joint. And we have seen these receptors, both receptors. So carotid sinus massage if you give, that will regulate the SA node and AB nodal rhythms. And then this is the blood vessels. Carotid artery, external carotid artery in the neck only gives all the branches. Internal carotid artery straight away it enters into the, no branches in the neck, it enters into the cranial cavity. And first artery is the superior thyroid. Anterior branches we'll see. Superior thyroid artery, it accompanies which nerve? Superior thyroid artery is a branch of external carotid and it is accompanied by the external laryngeal nerve. And so look at this is artery and this is a nerve. And you can see this superior thyroid artery, it gives one more branch called, the most important branch called infrahyoid. Above only you will be having the hyoid artery. So that gives the infrahyoid branch too. And it supplies the upper part of the thyroid gland. And look at this, the descending fibers are coming via that and it supplies the thyroid. And second is the facial artery. Facial artery, so how to clamp the superior thyroid vessel? So superior thyroid vessel you have to clamp near. See, look at this, artery and the nerves are very near. So here we should not clamp. Here the artery is away, the nerve is away. So the nerve is going towards the cricothyroid muscle. So here only we have to clamp the artery. So artery is to be clamped near the superior end. Superior end, it has to be clamped near. And look at this facial artery. Facial artery, it grooves which gland? Submandibular salivary gland, and it gives submental branch and palatine branch, tonsillar branches in the neck, and when it enters into the face, it gives a branch to the lower lip, upper lip. So inferior labial, superior labial and lateral nasal. It continues above as angular artery near the angle of the eye. That's why it's called as angular artery. We'll go to the next artery. That is the most important, lingual artery. So the nerve, lingual artery is going towards the tongue. So the nerve, hypoglossal nerve is also going towards the tongue. So they too have a relationship. Look at this, lingual artery, it loops. Can you see? It loops the hypoglossal nerve. Initially the first part is on the posterior border. Second part of the lingual artery lies beneath the hyoglossus muscle, the very important MCQ. And then the third part is coming out along the anterior border and it goes to the tongue. So first part, second part, third part, it lies in relation with the muscle called hyoglossus. It lies deep to the hyoglossus. Which nerve is lying superficial to hyoglossus is hypoglossal nerve. Nerve is above and the artery is below. And the next one is the occipital artery. Occipital artery is in relation with the posterior belly of digastric. It lies below the posterior belly of digastric and it goes to the posterior aspect of the occipital bone. And then this is the next artery, posterior auricular artery. This is occipital artery is lying along the lower border. The posterior auricular artery is lying along the upper border of the posterior belly of digastric. So it is going up. And this is a small tiny branch called ascending pharyngeal artery, is the smallest and first branch of the external carotid artery. And these two are the very important MCQs. Posterior auricular artery, it goes back and there is a groove in the mastoid notch, it goes via that. Anterior triangle. Anterior triangle, if you see, so many are there. Number 1 is the submental triangle, number 2 is the digastric triangle, number 3 is the muscular triangle, number 4 is the carotid triangle. So carotid triangle only we saw all the blood vessels, everything. Now will posterior auricular will not be there in the carotid triangle. Posterior auricular won't be there, so you should not include the posterior auricular. And the last two terminal branches also you should not include, superficial temporal and the maxillary artery. So only these branches alone you should write here. Occipital artery also, it has an can you see this loop of hypoglossal? So at the beginning, occipital artery, it loops the hypoglossal, and while going here the lingual artery loops the hypoglossal. So both the nerve loops both the arteries. Here the MCQ point of view I will discuss. Anterior belly of digastric, and this is a mylohyoid. Mylohyoid is supplied by the nerve to mylohyoid. The same nerve goes and supplies the anterior belly of digastric too. So both the nerve muscles are supplied by the same nerve to mylohyoid. Nerve to mylohyoid is a branch from the mandibular nerve, but look at the posterior belly of digastric, it is supplied by the facial nerve. So anterior belly is different and posterior belly is different, because anterior belly originates embryologically, it is developed from the first pharyngeal arch, and this posterior belly is developed from the second pharyngeal arch. That's why it has the mandibular division and it has the facial nerve distribution. And here you will be having the submental, only lymph nodes will be there. Submandibular, you will be having the submandibular salivary gland here. And then along the posterior belly of digastric, you have a very important muscle called stylohyoid. And next one is this sternocleidomastoid, already over. And then here you will be having all the strap muscles or infrahyoid group of muscles: sternohyoid, sternothyroid, thyrohyoid. These are the strap muscles, and the superior belly of omohyoid and the inferior belly of omohyoid. All these muscles are supplied by ansa cervicalis. What is that ansa cervicalis? So one is the cervical C2, C3 branch. They form a loop, that chain, that is called descending cervicalis. And then from the hypoglossal you have a chain that is called descending hypoglossal. They both join and forms a chain called ansa cervicalis on the anterior aspect of the carotid sheath. Carotid sheath is nothing but a modification of the deep cervical fascia. So it lies on the, can you see the, look at the chain nicely from the C to C3 cervical nerves and from the descendants hypoglossal. Descendant hypoglossal is nothing but a hypoglossal nerve will be going from here. From there a few fibers will be coming down, descending along with the C1 fibers. So they join with the C1. C1 is a cervical nerve which is purely motor, not sensory, purely motor, C1. So they join with the hypoglossal nerve and they go separately and they supply thyrohyoid muscle and the geniohyoid muscle. Thyrohyoid and geniohyoid are supplied by C1 nerve fibers along with the hypoglossal. But the descendant hypoglossal is the one which is coming down and forms the ansa cervicalis. This ansa cervicalis supplies all the strap muscles. That too, the descendant hypoglossal branch alone supplies the superior belly of omohyoid. So ansa cervicalis supplies all the infrahyoid muscles except the superior belly of omohyoid. Superior belly of omohyoid is supplied by the descendant hypoglossal, and the thyrohyoid and geniohyoid are supplied by the C1 fibers via the hypoglossal nerve. And last one is the thyroid swelling. Look at the nice dense swelling, which is, this is the thyroid cartilage, and this is the oblique line of the thyroid cartilage. Here only your sternothyroid muscle is getting attached. So this thyroid swelling cannot go up because of the attachment of this muscle called sternothyroid. So this is the oblique line of thyroid. That's the only reason the swelling cannot extend up. It can go down to the superior mediastinum, but it will not go up because of this attachment. Another one, thyroid gland moves up and down with deglutition because this thyroid is covered by the pretracheal fascia. So pretracheal fascia comes from here. So what happened, that is this deep modification of the deep cervical fascia. That is one part of the deep cervical fascia. So the deep cervical fascia, the medial aspect of the thyroid gland, posteromedially the thyroid gland is connected with the, beneath that you will be having the cricoid cartilage. This is thyroid cartilage and here it is cricoid. So from the cricoid to the posteromedial aspect of thyroid, there is a ligament called lateral thyroid ligament or ligament of Berry. Because of this ligament only, thyroid gland moves up and down with deglutition. And one more point, this ligament will be having its connection with the hyoid bone too. So this is the reason why it moves up and down with deglutition. And here something else is there as a midline swelling. This is your thyroglossal cyst. Okay, how this thyroglossal cyst is formed? See, normally the thyroid gland develops from the forearm area, forearm and cecum. There only your tongue is also getting developed. So after the thyroid gets developed, it has to come down. When it migrates down via the duct, that is called as thyroglossal duct. Glossy means tongue. Thyroglossal duct. Usually it gets obliterated after the migration of the thyroid. But when it is not obliterated, the duct area will become, that will be collected with the fluid that is called thyroglossal cyst. This cyst will be moving up and down with the protrusion of the tongue because it is related to the tongue. So it moves up and down with the protrusion of the tongue, not with the swallowing. But our thyroid gland moves up and down with the swallowing because of the ligament of Berry. These are all the part 1 clinical anatomy of the head and neck area. In part 2, we will be seeing the rest of the areas. Thank you. Hope this video is helpful to you. And if you have any queries, please do comment and ask the questions in the comment box. Thank you.